Hello everyone, this is Dr. Nikita Talreja, Research Associate at Wafer Chips, and your guide today through this webinar of understanding ECG fundamentals and significance of Holter monitors. To begin with, I'd like to brief you something about us. Wafer Chips is a medical device manufacturer and service provider, specializing in cardiac segment. Our product, BioCalculus, represents an extended version of the Holter device. Our core innovation lies in a patch-type device seamlessly integrated with proprietary AI software, offering a comprehensive solution for doctors and patients. Over the last 3 years, our product has positively impacted over 10,000 patients. Our mission is to reduce the stroke burden in our country and thereby improve the quality of life for general population. This section aims to explain the procedures necessary for installation. Biocalculus serves as a versatile device that caters to various cardiac monitoring needs, functions seamlessly as a Holter monitor, an external loop recorder, and mobile cardiac telemetry device. One of the standout features of Biocalculus is its impressive memory capacity, ranging from 1 day to an extended duration of 10 days, and further expandable up to 31 days. This extensive memory capacity ensures comprehensive and uninterrupted cardiac monitoring, enabling healthcare professionals to gather critical data over an extended period of time. Furthermore, the device operates on a battery recharging cycle of 4 days, providing sustained power without interruption. Its rechargeable battery system ensures consistent monitoring, offering an convenience and reliability to both patients and healthcare providers. Biocalculus is not only a cutting-edge device, but also eco-friendly and cost-effective as it is reusable and standalone monitoring system solution. This feature not only reduces healthcare costs, but also minimizes environmental impact, aligning with our commitment to sustainable healthcare solutions. In addition to the device itself, we pride ourselves on the comprehensive support we offer through backend analytics. Our platform provides robust analytics support, empowering healthcare professionals with insightful data interpretation, aiding in accurate diagnosis and informed treatment decisions. So let's get started. Arrhythmia. Arrhythmias are deviations from normal heartbeat pattern. They include abnormalities of impulse formation such as heart rate, rhythm or site of impulse origin, and conduction disturbances which disrupt the normal sequence of atrial and ventricular activation. So any abnormal heartbeat is an arrhythmia. So to know how an abnormal heartbeat looks like, you should know how a normal heartbeat looks like. Considering that you know the basic anatomy of heart, the heart has two upper chambers called as the atria and two lower chambers that are called as the ventricles. Normally what happens in a conduction system is that the natural pacemaker of heart, which is the sinoatrial node, generates an electrical impulse that is transmitted to the AV node, that is the atrioventricular node. During this, both the atria contract. Then the signal is transmitted to bundle of His and finally to the Purkinje fibers when the ventricles contract.
Normally, the sinoatrial or SA node sends an electrical signal that propagates out through the walls of the heart and contracts both upper chambers. Then that signal moves to the atrioventricular or AV node, and then it goes down into the ventricles or lower chambers, where it moves down the bundle of His into the left and right bundle branches, and into each ventricle's Purkinje fibers, causing them to contract as well. So in a healthy heart, the upper chambers contract first, then shortly after the lower chambers contract. On an electrocardiogram, the atrial depolarization, and therefore its contraction, is seen as a P wave. The ventricular contraction is seen as a QRS complex, and the ventricular repolarization, and therefore its relaxation, is seen as a T wave.
So this electrical activity of the heart which is recorded is known as the EKG or ECG. So in an ECG, P wave corresponds to the atrial contraction, QRS complex corresponds to the ventricular contraction, and the T wave corresponds to ventricular relaxation. The ECG is recorded on an ECG paper which looks like a grid, where time is measured along the horizontal axis and voltage is measured along the vertical axis. Each small square is 1 millimeter in length and represents 0.04 seconds. Each larger square is 5 millimeter in length and represents zero point 0.2 seconds. 10 millimeter is equal to 1 millivolt in voltage. Two main things you need to know to read an ECG are rate and rhythm. Rate is the number of heartbeats per minute, that is the pulse. So a healthy heart beats 60 to 100 beats per minute. To calculate the rate, what simply you have to do is count the number of boxes between two RR intervals. Put in the formula 300 divided by number of large boxes between two R intervals. Here the number of boxes are 4. 300 divided by 4, that is 75 beats per minute, is the rate. Rhythm. Heart rhythm is the pattern of electrical impulse that makes the heart muscles squeeze and pump. Rhythm may be irregular or regular. You can make out the difference by measuring the distance between two RR intervals. In the first case, the distance between two RR intervals is unequal, that is, the rhythm is irregular. In the second case, the distance between two RR intervals is equal, that means the rhythm is regular. Normal sinus rhythm. Keep in mind, any impulse originating from the SA node is called as normal sinus rhythm. It discharges at a rate of 60 to 100 beats per minute. The rate is normal, that is 60 to 100 beats per minute. Rhythm is regular. P wave is normal, that is positive and precedes each QRS complex. PR interval is normal, 0.12 to 0.20 second. QRS complex is normal, 0.06 to 0.10 second. You can well appreciate the P wave QRS complex and the T wave in the ECG strip given below. Moving forward to sinus bradycardia. If the rate of SA node is less than 59 beats per minute, it is called as sinus bradycardia. The impulse is generated through the SA node though, so it may be considered as normal. Features of sinus bradycardia are the rate is slow, rhythm is regular, P wave is normal, PR interval is normal, QRS complex is normal, except that the rate is slow, that is below 59 beats per minute. Causes of sinus bradycardia may be normal or abnormal. Normal causes, that are the physiological causes, include during sleep, when our body relaxes, our heart rate tends to go down. In athletes, their left ventricle is developed so much that they generate enough cardiac output. During vasovagal syncope, that is during intense emotional stress, some people experience sinus bradycardia. During vagal maneuvers like Valsalva maneuver, carotid sinus, baroreceptor stimulation, heart rate goes down. In physically active young individuals, it is not uncommon to find sinus bradycardia. Abnormal causes include myocardial ischemia, infarction, sinus node dysfunction, side effects of drugs like digoxin, hypothyroidism, hypothermia, that is when the body temperature goes down. Hyperkalemia is the electrolyte disturbance in which the blood potassium goes elevated. So heart rate above 40 during daytime is acceptable, but in severe cases, pacemaker implantation is recommended. Sinus tachycardia. If the rate of SA node is more than 100 beats per minute, it is called as sinus tachycardia. Features of sinus tachycardia include the rate is very fast, that is more than 100 beats per minute. Rhythm is regular. P wave is normal but may merge with the T wave as the rate is very high. PR interval is normal and QRS complex is normal. Everything is normal except that the rate is fast, that is more than 100 beats per minute. As the signal is generated in the SA node, sinus tachycardia is considered as normal. Paroxysmal SVT, an episodic condition with an abrupt onset and termination. Paroxysmal SVT is when the impulse is generated from a point just above the ventricle. That is what is called as supraventricular. And tachycardia, that is the rate is more than 100 beats per minute. So features of paroxysmal SVT are rate is fast, more than 160 to 250 beats per minute. Rhythm is irregular. T waves are regular but aberrant, difficult to differentiate from preceding T waves. PR interval is not measurable, and QRS complexes are narrow as rate is very high. The ECG strip given below, you can differentiate the rhythm is irregular, the rate is fast, PR intervals are not measurable, and QRS complexes are very narrow. Continuous cardiac monitoring is recommended for patients suspected with paroxysmal SVT. Causes are atrioventricular nodal reentrant tachycardia, that is AVNRT, Wolff-Parkinson-White syndrome, that is an abnormal patch of tissue that generates electrical impulse, atrial tachycardia. Symptoms manifest as palpitations, there is a feeling of fluttering in the chest, weakness or fatigue, dizziness or lightness, fainting, that is syncope, and chest pain. Treatment includes Valsalva maneuver. An episode can be stopped by bearing down or rubbing the carotid artery that relaxes the artery and reduces the heart rate. Medications that may reduce the heart rate can be used. Catheter ablation is considered as a first-line therapy for PSVT. In catheter ablation procedure, the tissue generating abnormal impulse is destroyed. Ventricular tachycardia. When the electrical signal starts in the ventricle instead of SA node, it is called as ventricular tachycardia. So as the signal is not starting in the SA node, ventricular tachycardia is abnormal. The rate goes very high in ventricular tachycardia. Ventricular tachycardia can further develop into ventricular fibrillation that is life-threatening. Features of ECG strip for ventricular tachycardia are rate is fast, that is 100 to 250 beats per minute. Rhythm is regular, P wave is absent, PR interval is not measurable as the rate is very high, QRS complexes are white and there is a bizarre appearance. You may have heard of sudden cardiac deaths that are caused due to ventricular tachycardia. Ventricular tachycardia and ventricular fibrillation need immediate treatment. They are medical emergencies. Types of VTAC and VFib are sustained VTAC and non-sustained VTAC. Sustained VTAC is a tachycardia that continues for more than 30 seconds and leads to hemodynamic compromise within 30 seconds and requires intervention. Whereas non-sustained ventricular tachycardia lasts less than 30 seconds and does not cause hemodynamic instability. Causes of VTAC and VFib are coronary artery disease, heart failure, myocarditis, enlarged heart, cardiomyopathy, heart valve diseases, previous heart attack, myocardial infarction or heart surgery that made a scar tissue on your heart. Certain inherited conditions are also causing VTAC and VFib. So basically the causes of VTAC and VFib are due to structural changes in the heart that has lost its capacity of elasticity. VTAC and VFib require immediate cardioversion, drug cardioversion, or electrical cardioversion. Certain drugs that reduce the heart rate are used in electrocardioversion to restore the heart's normal rhythm. Radiofrequency catheter ablation is a process in which radiofrequency waves are used to destroy the tissue which is generating abnormal impulses. An implantable cardioverter defibrillator, that is the ICD, is recommended in some patients. Atrial fibrillation. AF is the most common and sustained dysarrhythmia, and it is characterized by disorganized atrial electrical activity and contraction, resulting in irregularly irregular ventricular response. This is the basic characteristic feature of irregularly irregular impulse in atrial fibrillation. What happens in atrial fibrillation is that instead of a big contraction that contracts the atria together, there are small mini contractions which make the atria to quiver, and atrial fibrillation has a life-threatening complication of ischemic stroke. Types of AF are paroxysmal AF, persistent AF, and long-standing AF. Paroxysmal AF begins suddenly and stops on its own within 7 days, also known as intermittent AF, and lasts less than 24 hours. Persistent AF is when the AF is continuous and lasts for more than 7 days and fails to terminate spontaneously. Long-standing AF is when AF continues for more than 12 months. When the heart is beating so fast, the blood present in the ventricles tend to form clots. These clots then travel potentially to the brain and lodge into one of its arteries or veins, cutting off the blood supply to the brain, causing ischemic stroke. Features of atrial fibrillation are: rate is very fast for atria, but the ventricular rate may be slow, normal, or fast. Rhythm is irregular, P wave is absent, erratic waves are present. PR interval is absent. QRS complex may be normal but widened if there are conduction delays. Causes of AFib may be cardiovascular or non-cardiovascular. Cardiovascular causes are coronary artery disease and valvular disease. Non-cardiovascular causes are obesity and genetic factors. Treatment of AF includes medication to control heart rate and to reduce clotting. It is very important to start with OACs, that is oral anticoagulants, to prevent formation of blood clots and finally to prevent stroke. Implantable pacemaker and defibrillator is recommended in some patients. Radiofrequency catheter ablation process, MACE procedure in which new pathways are generated for normal impulse transmission, and AV node ablation. Atrioventricular block. Impulse conduction from the atria to the ventricle may be abnormally delayed or even blocked. That is when it is called as atrioventricular block.
Now, normally there's a delay in conduction at the AV node and the bundle of His, which gives some time for ventricular filling before the ventricle contracts. A heart block, or AV block, occurs when conduction is delayed for too long at the AV node or the bundle of His. On the ECG, the normal delay in the AV node is represented by the PR interval, which is normally less than 5 small boxes, or 200 milliseconds. There are 3 main types of AV block. First degree AV block is technically not really a block, it's more of a delay. Every single atrial impulse eventually makes it to the ventricles. The high yield concept here is that the only abnormality is a prolonged PR interval, and it's usually asymptomatic, so it doesn't require treatment. Second degree AV block has 2 subtypes, Mobitz 1 and Mobitz 2. In Mobitz 1, each atrial impulse encounters a longer and longer delay until one of them doesn't make it through to the ventricles. The high yield concept here is that on the ECG, this is reflected as the PR interval getting progressively longer and longer until all of a sudden the heart drops a beat. Like in Mobitz 1, the heart also drops a beat in Mobitz 2, except this time conduction through the AV node is all or nothing. Either the atrial impulse goes through with no delay, or it doesn't go through at all. Basically, there's no progressive prolongation of the PR interval in Mobitz 2. On the ECG, Mobitz 2 shows a couple of normal PR intervals followed by a dropped beat. Also, like first degree AV block, Mobitz 1 is usually benign and doesn't require treatment unless it's causing symptoms. On the other hand, Mobitz 2 can be dangerous and may result in severe bradycardia and decreased cardiac output. Therefore, it requires treatment with a pacemaker. Now, Mobitz 2 blocks can sometimes progress to our next type, the dangerous third-degree AV block. In this type, none of the electrical impulses are conducted through the AV node, and that's why it's also called complete heart block. So in third-degree AV block, the ventricles recognize that they're not getting any impulses and respond by generating their own electrical rhythm called a ventricular escape rhythm, just to hang on to dear life. Because the atria and the ventricles each have their own pacemakers, they now contract independent of one another, which is called AV dissociation. This desynchronization of the heart chambers can reduce cardiac output dramatically, leading to syncope or even sudden cardiac death. On the ECG, the P waves and QRS complexes have nothing to do with each other, each appearing at their own rates. The atrial rate is 60 to 100 beats per minute, whereas the ventricular rate usually ranges between 30 and 45 beats per minute. Because of how dangerous third-degree blocks are, Anyone diagnosed with it needs a pacemaker. Alright, so a lot of things can cause the three types of AV block. A myocardial infarction may involve the conduction pathway, causing a delay in electrical conduction. Also, electrolyte disturbances like hyperkalemia can alter the membrane potential. Then there are external causes like Lyme disease, medications such as beta blockers, calcium channel blockers, adenosine, amiodarone, and digoxin.
These blocks are caused due to some sort of damage or fibrosis to the conduction system. Signals are delayed while going from atria to ventricles. First degree AV block simply means that the PR interval is prolonged, that is 0.20 seconds. This indicates delay in the conduction of impulse from atria to ventricles, with most of the delay occurring at the level of AV node. Even though the signals are blocked, they still reach the ventricles. First degree AV blocks do not usually present with symptoms, so no necessary active treatment is required. Features of first degree AV block are rate, the underlying rate, rhythm is regular, P wave is normal, PR interval is prolonged, that is 0.20 seconds. QRS complex is normal. The characteristic feature here is prolonged PR interval. Second degree AV block. Second degree AV block has two types, Mobitz type 1 and Mobitz type 2. Mobitz type 1 happens when the PR interval gets progressively longer until it is blocked completely. Like first it may be 200 milliseconds, second it may be 300 milliseconds, and finally the next doesn't make it through the ventricles and the heartbeat is dropped. So features of ECG strip of Mobitz type 1 are the rate is underlying rate, rhythm is irregular but progressively longer PR intervals. P wave is normal, PR interval is progressively longer until a QRS complex is missed and then the cycle repeats. QRS complex here is normal. Mobitz type 2. It is similar to type 1. You get intermittent drop beats, but this happens randomly. There is no progressive lengthening of PR interval. ECG features are rate, atrial rate, usually faster than the ventricular rate, which is usually slow. Rhythm is regular of atria and irregular for ventricles. P wave is normal, but more P waves than QRS complexes. PR interval is prolonged and QRS complex is normal or wide. You can find more number of P waves than QRS complexes as the signal is not making to the ventricles. Second degree AV block might need treatment with a pacemaker. Third degree AV blocks are quite dangerous. It is the complete failure of atrial impulse to conduct to the ventricles. Therefore, only P waves will be present. Features are rate, atrial rate usually normal and faster than the ventricular rate. Rhythm is regular, but atrial and ventricular rhythms are independent of each other. P wave is normal shape and size but may appear within QRS complexes. PR interval is absent and the atria and ventricles beat independently. QRS complex is normal but wide if junctional escape focus. Causes of AV blocks are damage or fibrosis to the conduction system, idiopathic that is unclear cause, progressive over time the fibrosis develop due to aging process in elderly, and for younger people it may be hereditary. Ischemic heart disease or heart attack can also cause AV blocks. Treatment of AV blocks are identify the underlying cause and treat it. Example with medication or treat the infection. Medication to increase the heart rate like atropine may be given. Transcutaneous pacing through electrodes on the skin may be recommended, or permanent pacing is recommended. Ventricular standstill. It is sometimes referred to as ventricular asystole. Asystole typically is the absence of heartbeat. Ventricular standstill is when there is no movement in the ventricles. Features are rate, atrial rate usually normal and faster than the ventricular rate. Rhythm is regular, but atrial and ventricular rhythms are independent of each other. P wave is normal in shape and size and may appear within QRS complexes. PR interval is absent. The atria and ventricles beat independently. The QRS complex is normal but wide if junctional escape focus. Ventricular standstill is a medical emergency. It requires immediate CPR cardioversion. Temporary pacing wires and eventually pacemaker implantation is recommended. SA node pause. It is the failure of discharge of impulse from SA node within 2 seconds. Features of SA node pause are: rate is normal 60 to 100 beats per minute, but following the pause the heart rate will be slower, reflecting the duration of the pause. Rhythm: there is absence of P wave QRS complex for the duration of pause. And the ECG tracing appears flat during this time. As you can see in the ECG, there is a flat line. P wave is no P waves. PR interval, no P waves, so PR interval cannot be measured. QRS is absent of P wave. There are no QRS complexes. AV dissociation. It is a cardiac conduction defect where the atria and ventricles beat independent of each other. In AV dissociation, the atria and ventricles do not beat in synchronization. The rate of atria and ventricles can differ. Atrial rate is determined by the PP intervals, while the ventricular rate is determined by the RR intervals. Rhythm is irregular. PR interval is not measurable. The QRS complexes may be present on the ECG, representing ventricular depolarization. However, the QRS complexes may not be preceded by P waves. Junctional rhythm. The rhythm arising in the AV node is called as junctional rhythm or junctional escape rhythm. So the rhythm is starting at the AV node, not in the SA node. Features of junctional rhythm are: rate is 40 to 60 beats per minute, rhythm is regular, P wave is inverted as the signal is generated in AV node instead of SA node. PR interval is not measurable and QRS complexes are narrow. PVCs, that is premature ventricular contractions, are impulses originating from the ventricles that occur earlier than the next expected normal sinus impulse. Features of PVCs are: rate is the underlying rate, rhythm is irregular, P wave is absent, PR interval is not measurable, and QRS complexes are wide and they have a bizarre appearance. Types of PVCs are bigeminy, trigeminy, couplet, triplet, and run. Bigeminy is when every second beat has a PVC in it. Trigeminy is when every third beat has a PVC in it. Couplet is when two consecutive beats have PVCs in it. Triplet is when three consecutive beats have PVCs in it. When four or more beats have PVCs in it, it is called as run. Premature atrial complex. It is an early impulse originating from the atria. Features of PAC are: rate is usually normal but depends on the underlying rhythm. Rhythm is irregular. P wave is premature, positive, and the shape is abnormal. PR interval is normal or longer. QRS complex is 0.10 seconds or less. Premature atrial complex, it is related to the P wave, which is premature, positive, and abnormal shaped. Types are bigeminy, trigeminy, couplet, triplet, and run. Bigeminy is when every second beat has a PAC in it. Trigeminy is when every third beat has a PAC in it. Couplet is two consecutive beats having PAC in it. PAC triplet is when three consecutive beats have PAC in it. PAC run is when four or more than four beats have PAC in it. So we have completed the section of fundamentals of ECG. Moving forward to Holter monitoring. Holter monitoring. It is a non-invasive procedure that monitors and records your heart activity over prolonged duration. It is a palm-sized wearable device to record the ECG signals. It is able to record for a continuous period of 24 to 48 hours, but then 70% of the abnormalities are missed during this duration. Other drawbacks of Holter monitoring are: it has limited monitoring time of only 24 to 48 hours. It has limited diagnostic yield because of low data sampling. It has limited patient mobility due to many electrodes. The patient may feel discomfort due to that. It may also generate false positive results, because of which tests may have to be repeated. Indications for use are syncope, chest pain or discomfort, giddiness, palpitation, shortness of breath, cryptogenic stroke. So the suggested ECG monitoring technique for frequency of symptoms of about 2 to 3 days are in-hospital telemetric monitoring, if every week in-hospital telemetric monitoring Holter or external loop recorder is indicated, every month external loop recorder is indicated, if the symptoms are less than once per month, implantable loop recorder is indicated. According to the frequency of symptoms, monitoring time recommended is for every 2 to 3 days, 24, 48 to 72-hour Holter monitoring is required, and if it is less than once per month, 14 to 30 days of monitoring period is recommended. Biocalculus enables the ecosystem to generate more accurate clinical data by changing 1-day 3-lead Holter to 7-day 1-lead device. It has a single channel that is lead 2. It has 4 days of continuous operation and 10 days of onboard data storage. It tracks daily activities and it has cloud-based analytics. CCT certified reports are provided at the end of duration of monitoring period. Holter versus Biocalculus. The recording time for Holter is 1 to 2 days, whereas Biocalculus records for unlimited period of time. Activity, diary notes are provided, where the patient has to write down when the patient feels symptoms, whereas Biocalculus has auto detection. Irregularities like bradycardia, tachycardia, atrial fibrillation, atrial flutter, pause, SVE, VE, bigeminy, trigeminy, AV block, everything is recorded by Biocalculus. An analysis of Holter is made by ST and QT derivations, while Biocalculus provides you with CCT certified reports. Last but not the least, Biocalculus stands at the forefront of cardiac monitoring technology, offering versatility, extended monitoring capabilities, eco-friendliness, and robust backend analytics support. We are proud to present this innovative solution that not only improves patient care but also simplifies and enhances the workflow for healthcare providers. Thank you for joining us today.